Ladies and gentlemen, fellow colleagues, welcome to the special edition of the Cameroon Town Hall. Really, today we will be discussing part 2 of really how to address breast cancer in Cameroon and developing countries. So yesterday we had over, I think, 40-something participants, almost 50, which was wonderful at a certain time. And today we'll continue with the presentation. So if you can also share with your network, those who are interested, especially medical students and physicians back at home who treat breast cancer, would like to have a discussion. Really, today, it's going to be a bit more technical than what we discussed yesterday. So before I start, I would just love to do a brief introduction of who I am and why I'm doing this. So I am a trained physician from Cameroon. I was trained back in QS, and I have a passion really to want to educate the young generation and also hear their point of view about how to take care of cancer patients back home in Cameroon. And I did my medical studies back in Cameroon and also hold a master's in public health. And I did clinical pathology, then moved to the US, did internal medicine, and presently I'm a medical oncologist and hematologist. I do practice in Albuquerque, New York, in a Presbyterian hospital, where I am in charge of thoracic oncology. Also, I am an assistant lecturer at Richmond University Medical Center, where I do give lectures to fellows and to residents. So you're all welcome. And please, before we start, I would just like to say hi to everyone who is here. And please, it's a discussion. It's going to be a bit more technical. I think this is more designed to nurses, this session, but I would love patients to also log in. And if they have questions, they can always answer, and the general population. So before I start, I would love us today is going to be we'll do model 2 and 3 today, which is systemic treatment of breast cancer, how to adapt this in Africa. This is a highly oncology specialized discussion. My goal would be, like yesterday, try to make it in a simple way so that everyone who is present can really understand and get something out of it. As I said before, oncology is one of those fields where you need to collaborate with everyone else. The surgeons are very important. The radiation oncologists are important. The pathologists are important. Every person who is involved, the palliative care team needs to be built in such a way that we can be able to take care of these patients. So it's a team sport. It's not a one-man sport, and breast cancer is the same. In most of my presentations, I put up this book. Cancer is actually the emperor of all maladies. It is the disease that when you talk about, a lot of people are scared. Even physicians are very scared because a lot of them there were very few solutions back in the past in order to help and take care of these patients. So my disclosures, this presentation does not represent the views of Presbyterian Hospital where I work as an attending, neither does it represent the views of Richmond University Hospital where I teach from time to time. So we'll start with, this is a case, and this is a friend of mine who passed away, and she gave me her approval to always use her case in order to discuss this, because this puts in light why we are here today and why I decided to do this. So she is a 32-year-old Cameroonian female with no past medical history, and she was diagnosed with a lump in her right breast while she was working in Douala. So at the time, they did a biopsy, and The breast lump pathology indicated that she had invasive ductal carcinoma. At the time, she did not have an immunohistochemistry staining done, meaning that no one thought about doing the ER, the PR, and the HER2 stages. If you followed my lecture yesterday, I hammered on that point. The patient got a right breast lumpectomy back in Douala. The pathology also still did not test for ER and PR stages. At the time, the breast lump itself was almost 5 centimeters, and no lymph node biopsies were done for her. Then, a few months later on, she had a reoccurrence in the breast and later on got a mastectomy. And still did not get an ER and a PR status done, and still did not get a staging workup done. Just a few months after that, she started coughing and having bone pains. And one of the physicians decided to do a CT chest, abdomen, and pelvis and found out that she had metastatic disease all over. The real question at 32 was, right from the beginning, did she have metastatic disease? Most likely. Did this woman deserve to go through all the chemotherapy that she went through? Maybe and maybe not. Who knows? And she was wealthy. She was one of the few at 32. She was working at one of the big companies in Cameroon where she made more than $1 million CFA a month. So she could afford doing anything that she could. So the family was planning to take her over to India when I was contacted, since she was a friend. And by the time we went through Centre Pasteur and got an ER and a PR status, we got the results 2 days after she had died. And it showed that she was ER, PR 90%. And this was very devastating. She was ER 100% and PR 90%. This was devastating in the sense that everything that was done to this young lady with the aim of, and she knew she was being helped, but almost everything that was done to her was almost quasi-criminal because she did not deserve to have died. What was the reasons? I think there was part of it was the way our medical system is built, the way cancer is not one of those fields that there's high concentration on, and also the act of practicing medicine alone and not referring patients to specialties. So the goal behind this talk today is really to get everyone understand that we should work as a team and try to understand. So what would have been done to this patient? Right from the beginning, she would have had a staging workup because she was already stage 3 right from the beginning. And if she had had a staging workup and she would have had an immunohistochemistry, most likely, these are patients with ER, PR positive cancers that would respond very well to hormonal treatment. Even if she deserved chemotherapy or not, she would have gotten it the first time after the lumpectomy. So these are all things that we need to learn and understand. Yesterday, our model yesterday was we talked about screening, local management of breast cancer. I think this was more palpable because it's something which is easy to understand and to talk about. I would just do a little revision of what we spoke about. We talked about the risk factors for breast cancer. We did talk about modifiable and non-modifiable. Being a female, 1 out of every 8 women is going to get breast cancer. Now the question becomes, if 1 out of every 8 women is going to get breast cancer, being a woman is just the #1 risk factor for having breast cancer. That's the first. The second being aging as we age. So we had a plan in place. We talked about the situation in Cameroon. We had a discussion where we said, given that we're seeing younger patients, we need research in order to validate this point. But we concluded there are many means of prevention that can occur. We need to re-stratify. We need to train our GPs to understand how to re-stratify patients. There are several models out there. Any patient who has had an LCIS will have atypical hyperplasia. Those patients can be re-stratified using models such as the Guild 5-year re-stratification. There is also the Tyler-Cruset stratification. Those things are all found online. I think 99% of all those living in Cameroon have a phone that can access the internet. And by doing so, we could identify women where we can give them prophylactic treatment in order to prevent them from having breast cancer. And in Cameroon, this will fall in line with the gynecologists who see most of these patients. So you have tamoxifen can be used in premenopausal women, and then you have everything else can be used in postmenopausal: tamoxifen, roloxifene, exemestane, and anastrozole. We did present data. And you have to encourage these women to actually exercise and also to stop drinking alcohol and reduce the amount of alcohol. We did talk about mammograms and how do we adopt mammograms to Cameroon in the setting that we have, where we have our life expectancy in Cameroon is like 65. That's the life expectancy, 65. Do we adopt what is being proposed by WHO, starting screening at 50 and every other year? There was a whole debate yesterday. Or do we adopt starting earlier, like in the US, but doing it every other year for financial reasons and be able to get it so we can start at 40 and do screenings every other year? Another thing is we should train our GPs to be able to re-stratify patients who are 30-year-old and identify those who are at risk. And then we can start mammograms a bit early and ultrasounds. We did talk about MRIs for risky populations, but it's not available in Cameroon, so we didn't spend much time talking about it. The next take-home message was about really how do we stage patients? Who are the most appropriate patients for staging? Is it everybody that comes to your office that needs a staging workup? The answer is really no. For those who have stage 1 and stage 2 breast cancer, most of them may not need staging workup, but they need a complete metabolic panel. If you do that and you see the alkaline phosphatase is high, you need to do a bone scan. If they have problems with their liver enzymes, you need to do a CT of the abdomen. Most of the time, if they have abdominal pain or any other symptoms, but anyone with a stage 3, like my friend who passed away, needed a CT chest, abdomen, and pelvis during diagnosis. It is vital and needs to be done. Back home in Cameroon, we don't have PET scans, but that's optional. Let the strive for perfection not be the hindrance for our development, really. So we can always use what we have. That's what we need to do in order to strive. Now, in Cameroon, we hardly diagnose DCIS. Why? Because DCIS is a diagnosis that is done based on mammograms. And you need to do mammograms to see microcalcifications. If you're not able, you will not see. But if we do start doing routine mammograms, we'll be able to pick out DCIS. And these patients, how are they treated? You can either do a breast conservating surgery with radiation or a mastectomy. This was a debate also during our talk yesterday. Should we be doing mastectomy since we're unable to really get breast conservative surgery and tell us if the margins are negative or not? That becomes a big debate if women should be getting mastectomies for just DCIS. And all these women will need 5 years of either tamoxifen or aromatase inhibitor, depending on their menopausal status. We did talk about early stage breast cancers, and also today we'll talk about the oncological part of things. Today is going to be highly oncology sensitive. But we still said patients with invasive cancers which are localized, they can get breast conservative surgery plus radiation, or they can get a mastectomy. This is one of the areas where advocating for mastectomies without breast conservative surgery because we don't have radiation can be something to discuss, but it should not go for everyone. Doctors need to understand. We need to know those who can afford radiation. We need to know those who have very early disease, which you can omit radiation in our setting, and get them also to start hormonal treatment, especially if they're estrogen and progesterone positive. So these are all discussions that we can have and get to understand who can do what back home in Cameroon. That would be a very good research for us to be able to document so that we send patients to the right place. So today, I would start, as I always do, my cases with clinical vignettes, which help us to understand what is going on. So you are treating a 46-year-old woman who presents with a left breast mass. Core biopsy, as we always said, core biopsy is ideal. Do not do fine needle aspirations. For the surgeons who are in the line, they know about what that means. And also do not do excisions. The reason why we avoid excisions initially is because most of the time the margins are not going to be clear margins, and you would have to go back for a second surgery. Aesthetically, it's not good for the woman, and also it's just not well planned, and at times it's really, the outcomes are poor. Core biopsy disclosed poorly differentiated invasive ductal carcinoma. She was ER negative, PR negative, and HER2 negative. She's triple negative. What percent of our population does have triple negative? We don't really know for Cameroon because no study has really been done, but for the African population, it's about 20% to 30%, depending on where you are. Her tumor measured 3 centimeters, and she has at least one involved axillary lymph node. Which of the following statement is true? So how do we treat this patient? She's triple negative. She comes in, she does not have metastatic disease. How is she treated? The real answer is the addition of immunotherapy to anthracycline and taxane therapy. That's the D. And this becomes a big problem because this is the standard of care. Do we have immunotherapy back at home? The answer is no. Can we have immunotherapy at home? The answer is yes. Can we? Yes, but do we? No. So we need to advocate. We need to start advocating because these drugs have been out in the market for almost 10 years now. And we can advocate the same way we did for HIV and actually get these drugs available. And if they're available in India, then they can be available in Cameroon. Our next questions for discussion later on is, you are treating a 46-year-old premenopausal, take that word, she's premenopausal woman who has undergone a lumpectomy for a 1.2 centimeter mass. It was grade 1. Centenary lymph nodes were negative. That's how you do the standard of care. Breast cancer, and she was ER, PR positive, and HER2 negative. Her oncotype recurrence score was 10. The question everyone's going to ask me, how feasible is everything that I'm saying here can be done in Cameroon? Could we do a lumpectomy? Yeah. Are we trained to do lumpectomies? Maybe not officially, but all surgeons can do one, but we may need to standardize and get people trained. The question becomes, breast cancer markers, are they done in Cameroon? Yes. We can do ER, PR status. Bingo sends it to the US, Central Pasteur does it, and they send it to France and Senegal. You can get that result done. The oncotype recurrence score can be done. If you request for it in Bingo, they can actually get that done for you, but it's going to be expensive. There are other models to decide if patients are going to need chemotherapy or not, but majority of patients who are ER, PR positive do not need chemotherapy. Now, what do we do for this lady? She's premenopausal. So, do we give her chemotherapy? A lot of women in Cameroon get chemotherapy for the sake of NACO. That's what I'm going to call, even from oncologists, but she does not need chemotherapy. What she needs is to start her on tamoxifen. That is all. Is tamoxifen available in Cameroon? Yes. Can we give tamoxifen to this lady and prevent the cancer from reoccurring? The answer is yes. We'll get that in the end of this lecture. So you are seeing a 52-year-old woman with a T2N1 ER negative, HER2 positive breast cancer. This is the most difficult breast cancer to treat in Cameroon right now, just because financially it's very intoxicating. She has finished 6 cycles of chemotherapy with something we call TCHP. So she got the whole nuclear bomb, docetaxel, carboplatin, trastuzumab, and pertuzumab, and has undergone mastectomy and axillary lymph node dissection. Then her pathology report noted that her tumor bed showed treatment effect with residual tumor of 10%. The question becomes, what do you do? How do you treat her? We gave her treatment in what we call the neoadjuvant setting. Neoadjuvant in oncology simply means you're giving treatment before surgery. Adjuvant setting means you're giving it after surgery. So what do we give her in the adjuvant setting? We give her something else called trastuzumab extended. This is very important, but do we have this in Cameroon? Should we adopt this kind of strategy? This is expensive. We don't have this available right now, but I think places like hospitals like Bingo, they're getting this, and so you could get this standard of care in multiple places in Cameroon right now. But it's financially intoxicating. The question is, this shows you how complex oncology can be. And that is the reason why sitting in your office, you need to understand what the others can offer you and how the others can help in managing these patients. This is really very important. My goal is that the way we are training oncologists back home, but we need to have a strong surgical oncology department. We also need to have a strong gyne oncology department, and we need to have a very strong radiation oncology department, because our medical oncologists being trained, if they don't have these partners, they will not even understand what they can do. My radiation oncologist is in my hospital. He is my go-to person in discussing what to do for a lot of patients. He has a lot of solutions that I don't have. I have patients who have oligometastatic disease, which is progressing just in one area. And I call him, can you do an SBRT here? He looks at it and he says, yes, I can do an SBRT, and you continue with your systemic treatment. Then there are times that the surgeon can actually do palliative surgery. There are multiple times, so you need an interdisciplinary team. Even those with prostate cancer that come in to see me, and I have a patient, a young patient recently. She's 23 years. She's my youngest, with breast cancer, metastatic disease, with oligometastatic disease to the lungs. When I saw her initially, our plan was, okay, let's just do her systemic treatment. I did her genetic testing. She's BRCA positive. One other sad thing coming into place. Then I start her on chemotherapy and immunotherapy. She has a complete response. In the guidelines, I'm not supposed to do surgery. The question now comes in place. She had metastatic disease. Should I do surgery? I had to call my surgeons, call the breast surgeon. The breast surgeon she wants a double mastectomy. We decide to do her a double mastectomy. She has had complete response, because just being the fact that she's BRCA positive, we're getting out of the guidelines. And she would have a reoccurrence of a new breast tissue cancer. And in the future, for aesthetic reasons, that area could also reoccur and actually cause some ulceration and other things. She had a huge tumor. So now we're getting out of the guidelines, but the question is, does she even need chemotherapy maintenance forever? I had to stop her chemotherapy, keep her on just immunotherapy, and then start her on a PARP inhibitor because she's BRCA positive. This is the art of medicine when you're working with multiple specialists and everyone giving their input. That's how medicine should be practiced. So today we're going to have a little discussion about some of the general principles. I will try as much as possible to stay focused, because I know my audience is very diverse and I don't want this to become boring. And at any moment, if we're very boring, just stop me. Let's have a little chat. So we'll talk about the general principles. How do we treat? I'll start with triple negative breast cancer. It's the most feared, but it's also not as common as we think. It's more common in Africans. Almost 20 to 30% of all breast cancers will be triple negative. There is HER2 positive breast cancer, which we'll talk about. To me, that's the most feared in Cameroon. Reason being that the drugs are so expensive. All the oncologists know what to do, but how do they get trastuzumab and pertuzumab? That's the problem. Now, hormone receptor breast cancer, that's where we'll discuss. That's where 60 to 70% of all your breast cancers would fall. Now, for BRCA genetic testing mutation, I think there are multiple setups. Boya University has a lot of researchers who do genetic next generation sequencing in their research labs. And I would want to know from them if they're able to test for certain genes like the BRCA gene. If they're able to do that, I've had multiple Cameroonians who have been tested, and a lot of them have Li-Fraumeni and BRCA1 and 2 in the US. So it's not something that is not available, that is not found in our community, just that we have not tested. So under the general principles of systemic therapy, the first part of this lecture is in the non-metastatic setting. I just want to clarify things. The second part will be in the metastatic setting, and what do you do? In the non-metastatic setting, there was a paradigm. We talked about the Hallstatt policy, where we believed that by doing surgeries, we could eradicate breast cancer. We could remove it from its roots. And that was the Hallstatt method of surgical approach, which we did radical mastectomies. We talked about that yesterday. And we found out that patients still reoccurred. But now, how do we help them? Systemic therapy, chemotherapy was the first form of systemic therapy that had been used. We need to be able to identify not doing harm to patients versus helping them live longer. Each time in medicine, you should not do harm. But the Oxford Review, which in the UK, the interesting thing about the UK is that we have had a unified health system for a long time, and we can actually see the impact of things. After this analysis was done in 2012, it's a whole data for more than almost 50 years. They found out that giving chemotherapy actually helped improve survival in patients with breast cancer. The same Oxford data was used for tamoxifen for those who had ER-positive breast cancer, and we can see what we have done over the years. By giving tamoxifen to the right patients, we did improve survival. So this is the paradigm behind what we're doing. We have looked retrospectively, and we have seen that we are helping patients by what we're doing right now. And we've seen that this is actually a strategy to use. Let's go back to the lectures of yesterday. What are the important things that we talked about? Diagnosis should be done via a core biopsy. Everyone should keep that. Please do not do a fine needle aspiration for women who come in with breast cancer. Even if you can, don't do it. You will not be able to differentiate DCIS from invasive cancer. You're going to render your pathologist mad. I was a clinical pathologist in Cameroon. You're going to render people mad and angry with you. Now, the next thing is every woman, their last money they have when they come to see you should be used to do the ER/PR and the HER2 status. That is the last 80,000 francs they have. I actually investigated, so I can tell you where to send it for 80,000. Send it to Bingo, they'll do it for 80,000. You can send it to Centro Pasteur. That's the last money they have. Why? Because without knowing the ER, the PR, and the HER2 status is criminal. In the way you manage breast cancer is criminal right now. There are many other things I do in the US. I do a next generation sequencing. I do oncotypes. I do mammo print. I do a lot of things, but that's not what you should be doing. Do this. Once you do this with the last 100,000 they have, you would have clarity about what to do with them. I have my patients come in even here in the US. Their first thing they tell me, the ultimatum they give me when they get into my office, because the breast surgeon sees them, sends them to us, sends them to radiation. They say, Dr. Kenne, I do not want chemotherapy. I say, Liz, I just say Liz or Elizabeth or whoever. You may never even need it. So that's even my response. First of all, I don't think you even need it. Even when I looked at the pathology, I can predict. I say, you will not need it. So we'll not have to even fight that fight, because I know most of the time her oncotype is going to be less than 25. Don't confuse intraductal carcinoma from invasive ductal carcinoma. Invasive lobular carcinomas are always ER positive. Keep that in your mind. If a pathology comes to you and you look at it in your office and it says lobular carcinoma, 99% of the time, the ER/PR status will be almost 100%. The HER2 status will be most likely 0. So keep that in mind. Know that if you're living in a poor resource country, you have someone who is poor, the 30% of patients who have lobular carcinomas, they are always ER positive, always. If I have a lobular carcinoma in my office and the result comes back and it says ER/PR negative, I call the pathologist and send it back to them. Mrs. or Mr. Pathologist, restain this thing. I don't think it's true. But there are cases, there are anecdotal cases, you don't need to forget that. There are cases where it's ER/PR negative, but it's less than 1%. So don't do systemic staging in all patients with stage 1 disease. But you should actually be able to do blood work and determine those who need it. Everyone with stage 3 disease needs systemic staging. To me, I'm going to talk about treatment today, but that's not the most important. These are the most important slides in all my presentation. If all the GPs, the surgeons, the gynecologists can take this information back home, the nurses that work with these patients, the oncology nurses that are here, and everyone else who is an advocate for breast patients can take this home, that would be good. In the US and in Europe, what we found out is that 80% to 70% of all breast cancers are ER positive. There is a subset that is HER2 positive that complicates things, but about 15 to 20% of all breast cancers are HER2 positive. Triple negative ranges from 15 to 20. In Cameroon and Africa, we're towards the 20. Most Caucasians are less than that. They're actually like 10. So This is something that has not been investigated, and I always encourage us to do more research. Research is never bad. So let's use our medical students to get our own data. We don't want parachuting research where we get data from Europe and from France, and then we parachute it into Cameroon and think that's how we are. We are different. Now, how do we, fundamentals of my lecture is going to be still this. How do we, even in the adjuvant and in the metastatic disease, how do you approach these cancers? So I would start with the population, which is the majority of what you would see in your clinic. The majority of what you would see in your clinic are those who are hormone positive and those who are HER2 negative. They form 60 to 70% of all breast cancers in Cameroon. The main treatment is endocrine treatment. Main treatment is not chemotherapy, what I see all the time. People get chemotherapy like they're getting water. Main treatment is endocrine treatment. That's what is going to improve mortality, plus or minus chemotherapy, plus or minus CDK4 inhibitors. I'll tell you guys what CDK4 inhibitors are. They can be gotten. I had a patient in Nigeria recently. I had one in Bamenda. They got her palbociclib easily. I think there's Noble Pharmacy. He could get it for her easily, palbociclib. There was not ribociclib and abemaciclib, but she got palbociclib easily. She had metastatic disease. Now it's 1 year. She's in complete remission. Complete. She didn't even see an oncologist that I discussed with one of the doctors. She was started on tamoxifen and Pablo. She's spending less than 60,000 every month, and she is in complete remission. Complete. So the second thing we would always look at hormone receptor positive and HER2 positive. HER2 always triumphs everything. In these cases, chemotherapy and HER2-directed therapy is standard of care plus endocrine therapy. This is sad in Cameroon because we really have problems acquiring and having these drugs, and they are very expensive. So we need advocacy because trastuzumab right now is supposed to be generic. So if the government can play a role in making it available, that'll be good. Now, those who are hormone receptor negative and HER2 positive, these patients get chemotherapy and HER2-directed therapy. We'll talk about that today. And finally, those who are hormone receptor negative and HER2 negative, these are our triple negative patients. These are the nightmares for all oncologists, breast oncologists, including myself. But there is progress going on in this field right now, but it's not yet available in Africa. We have chemotherapy standard of care. I've validated that this chemotherapy, the regimens, the best regimens, the areas I know, the people I work with can be given in bingo. They are able to give docetaxel and paclitaxel. They are able to give that without any problems. But they are not able to give immunotherapy because it's just not available. Now, so today in the non-metastatic setting, we're going to start with a triple negative breast cancer. What are the general principles behind us managing triple negative breast cancers? They have one of the highest risks of reoccurrence. Chemotherapy is generally given preoperatively. Then stage 1 patients, I don't want to go into the details, but those who are oncologists, you can take my slides. I'll share it to you guys later on. It's anthracycline, taxanes plus or minus carboplatin. For those who have stage 2 to stage 3, you do the same thing, but you add immunotherapy. And this is just a summary of the whole lecture. Capecitabine may be offered for residual disease. That's all. This is all you need to know. The thing about, there's so much research going on. I'm not going to flatter you guys here with things that we're doing, which are going to, things in the future. There's a lot going on here. But the following data after this is just justifying how we came to this. So preoperatively, there have been clinical data that has shown that by doing preoperative chemotherapy, that's what we call neoadjuvant chemotherapy in triple negative patients, we improve mortality. That's just, there's data out there for those who want to say this was published in the Lancet. There is so much data, non-contradictory. We also do know that some chemotherapies we call anthracyclines, they are better than taxanes. We know that. And there is data out there. But the problem with these anthracyclines, this is for medical students, is that you need to know cardiotoxicity. If you're coming to write USMLE, that's going to be the first thing they'll ask you. Cardiotoxicity, which is non-reversible, okay? You need to know that. When these patients are getting chemotherapy, we do echocardiograms every 3 months. This is the star of the show. Before this, nothing had moved in triple-negative breast cancer, even in the neoadjuvant or metastatic disease for years. For 50 years, nothing had moved till we had the keynote 522. For those who are here who are new, each time you hear the keynote, we're dealing with an immunotherapy called Keytruda, called pembrolizumab. It's the most common drug before you had the medications now that we use for weight loss. What's it even called? There is this medication for weight loss that is the most popular medicine on earth. But before that, Keytruda was the most popular medicine on earth for many reasons. Keytruda has been incorporated in almost all cancer treatments. That's immunotherapy. We'll look for time and talk about that. But by adding immunotherapy in the neoadjuvant setting to what we are doing, we were able to improve overall survival, progression-free survival, reduce mortality. This is the standard of care for those who have at least stage 2 disease. That's how they are managed in Europe, in the US, and in Asia. Now, how can we get Keytruda in Cameroon? If we cannot even get Keytruda, how can we get other immunotherapies? We need advocacy. We need strong advocacy like we did for HIV. This is just the data for those who are data-driven. Those who are oncologists, this is what the data looks like. You could see that with percentage of patients with event-free survivor. Here is for medical students. If you're coming in to ever think about writing the US MLE, you're going to be tested on this. You need to know the side effects when you're giving this drug. Main side effects are going to be thyroiditis, occurs like almost 20% of those patients that develop hypothyroidism. They develop the itis. Just think about it. Anything that can cause inflammation. Immunotherapy is actually helping your immune system to fight cancer. That's what it does. In oncology, what happens with your cancer cells is that they produce do not kill me signals. They call them programmed dead ligands. They produce do not kill me signals. And the Keytruda comes in and blocks the do not kill me signal, and the immune system sees them. The immune system is able to see now. When I was not able to see, now I can see. So most of you know about Professor Anomango, and maybe you don't. I was fascinated by him when I was in medical school. He was, to me, he's one of the biggest geniuses the world has ever created. This guy understood immunotherapy back in the 1960s. If any of you are here, do you know the second prize after the Nobel Prize for Medicine is called the Lasker Prize? Anomango is one of the few Africans who has won one, and he won it in 1960 for Hodgkin's lymphoma. I know most Cameroonians don't know that. That's how wonderful that guy is. All his theories behind treating HIV was all immunotherapy, but that's a discussion for another day. He just had people working with him who were not intelligent enough. I don't want to use that, but who were not futuristic enough to have taken his ideas further. That's why always encouraging the young Cameroonians to think outside the box. Now, I did show you data. I said this was all going to just be talking about things that we know. You have data here showing that if you do the treatment I've given you now, and patients later on go in for surgery and they have residual disease, what do? There is data showing that you can give them capecitabine for those who have residual disease. And this is the data. This is how much it reduces mortality. It's statistically significant. Patients live longer. This is just something, you must not keep this, but it's for the medical oncologists in the field. I can be able to share my slides so you guys can have it. In summary, how do we treat patients with known metastatic disease who have triple negative breast cancer, 20% of our population of women? 20 to 25% is that we can give them anthracycline-based chemotherapy. For those with stage 2 and 3, since we don't have immunotherapy, we're still going to do this. But if we do have, and they're financially capable, they should get immunotherapy. And if they have residual disease, then we give them capecitabine. If no residual disease, we continue immunotherapy for a total of 1 year. That is the standard. Now, let's go over to the next group of patients. As I said, each time I'm going to start with a summary. HER2 positive breast cancer. This is why I said it's criminal. If you're realizing with my lecture now, the treatment differs depending on what you have. It's criminal not to test it. It's just criminal not to test it. How are you treating it? That's the question I'm going to ask you. How are you treating it if you did not test it? So if they have their last 100,000 francs, or someone wants to help them, get that test done, please. So this makes about 15 to 20% of invasive breast cancers. 20%, 15. HER2 positive is defined as immunohistochemistry test IAC of 3+ or 2+ plus a fish, which is positive. This to me is now one of my biggest advocacy where investment needs to be done. For me as a medical oncologist, if I want to invest in anything, it's going to be IAC and pathology. What are the general principles you need to take home? Is that those who have a small lesion, breast cancer, very small, less than 2 millimeters, less than 2 centimeters, you can go ahead with surgery. But generally, we don't encourage going ahead with surgery. And then you can de-escalate, give them. All what we know is that giving these patients trastuzumab and chemotherapy. Trastuzumab is the HER2-directed therapy. It's called Herceptin. You guys know the word, Herceptin. Even when I was in medical school in Cameroon, I think I knew about this. Professor Doe spoke about this in one of our lectures, Herceptin, with chemo after surgery. But everyone else from stage 1B going forward, they need neoadjuvant treatment. That is why you need to test this. Because the standard of care is not for you to rush and go do surgery. The surgeons need to know this. The gynecologists who are treating breast cancer in Cameroon need to know this. You should not just, a patient who comes in with HER2 positive, you should test, should get chemo first with HER2-directed therapy. Now you ask me, if they cannot afford trastuzumab, which is like 200,000 for one treatment in Cameroon, for those who can get it, what should I do? This is a sad situation, really, that we're dealing with. Then, in that situation, you know what the standard of care is. You know that what you're doing is suboptimal, but you get to do it. Before the discovery of Herceptin in 1999, that was one of the first targeted therapies. Medicine got flipped on its head. HER2-directed cancer was the most riskful cancer we ever had, but things changed from 1996. That was the first standing ovation, one of the first standing ovations. These categories of drugs have had 2 standing ovations in ASCO. The first one is in 1996. The second one was 2 years ago. In ASCO 2 years ago, there was a shocking revelation that put breast cancer on its head. Why did it turn breast cancer on its head? Is that we got to realize that patients who can respond to a medication called trastuzumab deruxtecan actually changes the way we're going to classify breast cancer going forward. Pathologists are still resisting it, the way we're going to classify, because HER2 is a spectrum. Patients who are 1+, 2+, and those who are ultra positive, or they do respond to some form of HER2-directed therapy. That will be another discussion. So this is the first study that actually flipped. This cancer was the most risky of all cancers. HER2 was a receptor that was actually originally identified in the brain, but is the human growth receptor, which is actually in breast cancer predicts poor prognosis, very poor prognosis. With HER2-directed therapy, this has become normal. So in addition to, I am not a big fan in Cameroon for you guys to be giving pertuzumab, because this is what we call the affinity trial that added pertuzumab to trastuzumab. You see the importance. In those who were node positive only, there was an improvement. And there was a very little improvement. If you can give trastuzumab, pertuzumab is super expensive. It's like 500 to $1 million. Now, if you can just give trastuzumab to these patients, you're going to make a big difference. But you should know those who can afford it can get trastuzumab and pertuzumab. That is something you can do. But you should know that if you have to do something, we're in a resource-poor country, we should select very well for our patients. Now, if in the neoadjuvant setting, you get these patients, you give them trastuzumab and chemotherapy, and then they go for surgery. That's why this is a team sport. They do surgery. Pathology tells you that I still have residual disease. What do? You escalate it to something called TDM1. It's called trastuzumab extended. That's how they were treated. This is the trial. It's called the Catherine trial. I don't want to go into this. This is going to be more for oncologists, but you see here that there is benefit in giving them this treatment once you have residual disease. My goal is that you should know what is supposed to be done. For those who can afford it, we afford. Those who can advocate, those who work in the ministry, who understand the importance of these drugs, we can now make some of them to get into the essential drug list. And then we can use them and treat breast cancer patients. It's the most common cancer in Cameroon. This is the slide you should take a picture of. Each time I present a slide which is, a lot of you, it may be very surprising, but this is a lot of hard work in putting the slides together. This is a summary of what you should do. If you think a patient is stage 1, you have staged them, you have sent to the radiation doctor, they have done a mammogram, it's a small mass, there is nothing anywhere, it's less than 2 millimeters, you're able to do surgery first and later on send them to the medical oncologist for them to get just even Herceptin or paclitaxel and Herceptin. Those drugs are found in Cameroon. Please use your medical oncologist. For those who have stage 2 and beyond, they need neoadjuvant therapy. So if you're in Bamenda, you send them to Dr. Kuya Francine for her to give them treatment first before they send them back to you for surgery. And after surgery, if they have residual disease, you send them back to Dr. Kuya. That's how it works. I'm just giving you guys how it should work. If you're in Yaoundé, you do the same. You should not colonize these patients and feel that you can treat everything that is going on. There is a whole standard of care. And very soon, Cameroonian patients will get educated and they'll be litigating people. Now, our third and most popular group that you will find in your practice will be those who are hormone receptor positive, HER2 negative. These patients make up 60 to 70% of your practice. And how do you approach this patient? Do all patients need chemotherapy? Those who in the adjuvant setting, do they really need it? The answer is no, most do not. In the US and in Europe, in the US, we use the Oncotype more. It's based on something we call the TELO-X trial and the R-respondent trials. In Europe, they use the mammoprint because a lot of Cameroon, I put this here because a lot of your data, a lot of what you do in medicine comes from Europe. They use the mammoprint. When do you consider genomic assay? You consider genomic assay in everyone with a node-negative breast cancer needs to have genetic assay. The goal for the genetic assay is to see if they have greater than 5 millimeter tumor, you need to do a genetic assay to see if they need chemotherapy or not. But this becomes strange. In Cameroon, we don't have the oncotype. We don't have the mammoprint. But can we, in our research centers in Boya, in Yaoundé, especially in Boya, I know Boya has a lot of people from COVID that are having all the NGS they are doing over there. Can we actually get some of these tests, get partnerships and be able to do this? But there are other models in place in resource-poor countries where you can use the Ki-67 and other models to decide if they will need chemotherapy or not. If you're doubting, don't give it to them. So, and also for those who are having lymph node positive disease, do all of them even need chemotherapy? The answer is no, especially those who are postmenopausal. 1 to 3 lymph nodes do not still need chemotherapy. You need to still do those tests. This was the clinical trial, which I will not go into details because we are not lecturing oncologists here. The goal for this was just to figure out how was this done? How did they come about? We realized that those who had an oncotype score of less than 10, their survival was 99.3%. Those who had an oncotype between 11 and 25, they did a randomized trial, randomizing them to hormonal treatment alone versus hormonal treatment and chemotherapy. There was no difference. Sadly, we're giving many people chemotherapy for no reason. And then those who had above 25, there was benefit. That is actually what this data says. So this is all data-driven. Getting an oncotype, we need to invest in trying to see how we can get this technology to Cameroon. If we are not able, here you can see those who had a score less than 10, survivor 99. Those who had a score between 11 and 25, there was no improvement in giving them chemotherapy. So chemotherapy was just hurting these patients, giving them side effects and killing them. This is now the standard of care you need to take home. The question I'm not going to insist on this is that we don't even have the oncotype. So we need to be practical. What else can we use? There is a risk assessment score that can be used. You can get that online. You can plug in the lymph nodes. You can plug in the Ki-67. You can plug in the grade, and you'll be able to predict if these women may need. It's not very good, but it's the best we have. What about node positive disease? There was the R respondent trial, which I'm not going to go into the details. All what this tells you is that not all women who are postmenopausal may not even benefit from chemotherapy if their oncotype score is less than 25. But those who are premenopausal, the young girls in Cameroon who are having breast cancer, they do need chemotherapy before placing them on hormonal therapy. That was the take-home message. Now, which chemotherapy do we give? That's a very interesting question. Which chemotherapy should you give a patient? If you're treating patients with breast cancer, is there a special chemotherapy? We call it the alphabet salad, meaning that there are so many options, please. But I'm highlighting this because I don't know about Yaoundé very much, but I've been working with Bingo and Dr. Francine Couillard. She's able to give those dense AC plus paclitaxel because they do have Neulasta. So they're able to do this. It's shorter, it's more efficient, and patients get to finish earlier. So this is a good regimen that can be given in Cameroon. Docetaxel and cyclophosphamide can also be given in Cameroon. They do both in Bingo. And I keep quoting Bingo because I've attended La Cantine's tumor board. I have a lot of friends in Cameroon. I've attended La Cantine's tumor board. I've attended tumor board in, we have a little group that we present cases. So far, despite being in the Northwest and all of that, they are the most progressive. The rule of adjuvant CDK4 inhibitors, this is just new stuff coming out of the kitchen right now, is that at times, even in high-risk patients, they may not need chemotherapy. You can just give them a CDK4 inhibitor plus hormonal treatment, and they will do just fine and even better. This is where it's moving to. Most of those patients will be treated the same way you treat them in a metastatic setting. Right now, there is approval for 2 drugs. There was first approval just for one. One is called abemaciclib. The other one is called ribociclib. These are CDK4 inhibitors. We'll talk about them very soon. This is another advocacy we need in Cameroon because majority of our patients do have hormone-positive breast cancer. Despite triple negative being high in Cameroon, majority do have hormone-positive breast cancer. So we need to advocate to get these 2 drugs available. So what is the summary of this discussion? Take-home message is that hormone receptor positive HER2 and PR is defined by greater than 1%. That's a debate. Some people say 10%, but the recent WHO and the NCCN guidelines says 1%, but most of those with 1%. I treat everyone with less than 10% as triple negative. Menopausal status is diagnosed before you start treatment. It's very important to know their menopausal status. What is menopause? It's actually a woman not seeing her menses for 1 year. You don't need to test them. If it's less than 1 year, you need to be able to define it and test them. You can do estradiol levels. You can do follicle stimulating hormone and luteinizing hormone levels to determine. Now, low risk 5 years and high risk, you can give them therapy. That's the tamoxifen you guys have in Cameroon. You give them tamoxifen for 10 years. If a woman cannot afford chemotherapy and you have done surgery and they have ER/PR positive breast cancer, the chemotherapy is not the important part of the treatment. Please, guys, don't let them go spend millions on chemotherapy. The most important part is putting them on tamoxifen, not the hormonal, not the chemotherapy part. Also depends on tolerance. In Cameroon, I do know we have tamoxifen. For women who are premenopausal, high risk, you can actually give them ovarian suppression. We have those drugs. Lupron is found in Cameroon, though it's expensive. I've provided it for many men who have prostate cancer. So take-home message is that, are the drugs available? Yes. For the most populated or the most frequent cancer you have in Cameroon, yes. Do we have tamoxifen? Yes. Do we have aromatase inhibitors? Yes, I found out. But they are not being used. We have anastrozole, letrozole, and exemestane in Cameroon, and they are affordable. So for the medical students who are on the line, what you should know, if you're planning to come to Europe or you're going to England and you want to do tests, tamoxifen, the things you should remember is that it increases risk for DVT, it increases risk for uterine cancer. That's what gave it a bad name. It causes hot flushes, cataracts, and menstrual irregularity. While your aromatase inhibitors, anastrozole, letrozole, and exemestane, I always tell my patients, I make an analogy that these are 3 triplets born from the same mother, have the same characteristics, but they have different characters. It means that in the beginning, we don't decide on how to choose from them. All three of them are equal. But some women may have side effects from one without the other, so you can switch in case of side effect. They have muscle and joint cramps and aches, vaginal dryness, bone pain, and hot flushes. Do not give to premenopausal women aromatase inhibitors without doing ovarian suppression, please. Do not do that. So this is just the data showing you that aromatase inhibitors are better than tamoxifen. So if you have a woman who is post-menopausal, aromatase inhibitors are better, but they can cause osteoporosis. Black women don't have osteoporosis as much as white women, so don't be worried about that too much. This is data for oncologists, switching methods and all of that. I don't think you guys need to know this. The last question is duration. How long should you give it? So usually if a woman tolerates very well, give it for 10 years. If they don't, I give it for 5 years, but there is a score. High-risk women need it for 10 years or 7.5. There is the breast cancer index score that we use in order to determine the duration. And it shows that those who have a high breast cancer index score needs the medication for 10 years. Here is the most recent NCCN guideline. It looks complicated. This is a marvel to move, but please, take-home message is just those 2 lines behind. At least 5 years endocrine therapy for everybody who has ER-positive breast cancer. Up to 10 years treatment for those who have high-risk patients, stage 3, lymph node positive, oncotype score greater than 25, high, very high. Those are the patients you need to give them this for about 10 years. That's all. Forget about this. You get into the NCCN and you get confused if you're not an oncologist. This is the take-home message. Now, why do we even need to do genetic testing? Why do we need to find out from Boya if they're able to do all germline testing? Because there's treatment. There is treatment in the adjuvant and in the metastatic setting. There is a drug called olaparib, talazoparib, which they are all PARP inhibitors. You can give it to these women in the metastatic and non-metastatic setting to help them. That's why we need to know if you guys can do it. And that's why women need to be referred to do it. And we need to make them cheap and available. There is data. This is called the Olympia trial. And that is the end of the first part of our lecture today. The second part, we'll talk about the metastatic setting. So I would stop for a while for us to discuss if we have any questions. I see there have been chats which I have not read in the inbox. Okay, so please, you can unmute yourself. This is just, to me, the way I do this is more for us to have a chat. For those who have sacrificed their time and they're here, we have a chat about what you guys think, at least 5 minutes before we go to the second part. So please, you can unmute yourself. If you have questions, just unmute yourself and let's talk. So someone is talking.
Sorry, Doc, I have a question. My
Yes,
question
Chris.
was with respect to, sorry, my child is crying in the background. My question was with respect to, because you were talking about HER2, I know you said it's really a rare one. And then in terms of the use of these medications.
Trastuzumab, yeah.
Yes, trastuzumab. So I was wondering, given that probably it's higher quality and better, and it's more expensive for someone in Cameroon. I'm saying that is because I had an aunt who had it, and through the Pacha Foundation, we're able to get this medication for her, and it really helped her. So my question would be, will the number of sessions or number of doses for use of this medication be relatively reduced compared to what is existing in Cameroon?
Yeah, in order to do, so this is the most interesting thing, Dr. Crespo. We need research. We need research in order to adapt things, okay? We need to do our things the African way, but we should come across with research. I would be able to tell you that I want to reduce the number of doses, but the question is it adequate? So how is it even given? I'll tell you how it's given. It's given with chemotherapy, 6 doses, then the patient goes for surgery, comes back after surgery. If you have no residual disease, you continue the treatment for a year. Can we do 6 months? There have been de-escalation trials that have occurred in the US. Can we do 6 months? Can we do just trastuzumab without doing pertuzumab? There have been trials. So there are patients who come to me, I don't want to take it for this. And I go in and I see that there are trials in Japan that show that 6 months is almost equal as 1 year. And I do 6 months. We need to do those trials in our people. We need to start doing research and just not assume we are different. And we need to encourage the pharmaceutical company to come invest with us. And we need those who are our leaders. We have a lot of Cameroonians that run pharmaceutical companies abroad. We need to have an open policy to get them in. I know of a Cameroonian who worked in Pfizer. I was not doing vaccination, but I'll tell you, I tried for Cameroon to get almost $1 billion. It was a huge amount of money when the guy contacted me to do clinical trial on COVID. It was almost impossible. I was told that it could not happen at the time because there were a lot of political reasons, okay? So we need to encourage the environment, use our medical students and nurses well, and researchers, those who are doing basic science, to know what we can do. So that's the way forward. Now, trastuzumab has been existing since, I told you it was approved in 1996. It's now generic. Why should it be that expensive in Cameroon?
Yeah.
So why should it be that expensive in Cameroon? Why? It's generic, so it can be made in India. Why should it be expensive? It should be part of the essential drug list. It should be. That's where the advocacy should go. I'm going to talk to Dr. Yauba, who is in charge of the Clinton Foundation, and see how he can advocate for this, because that's really where it goes.
Yeah.
Need advocacy in order to make these drugs available. I was perplexed the day I heard the price. Do they even need pertuzumab? Pertuzumab is not yet generic, but pertuzumab was added in 2010 to the protocol. They don't actually really need it. When you look at the affinity trial now, I believe in medicine that can be adapted in our environment. Maybe the difference between me is that I did most of my time in Cameroon. A lot of people don't know that. I actually studied medicine in Cameroon, specialized in Cameroon before moving to the US. So I have a different perspective. I respect all the colleagues back home. Super intelligent. We are just dealing with an environment which does not encourage research, encourages mediocrity. That's really what is going on back home. There is isolated people who know what to do, but no one even listens to them. No one thinks they are good enough for them to even have a voice. So they leave France, they leave Switzerland, they come here, they are frustrated, and they sit in their practices alone, and then they develop the Cameroon way, where they are surgeons, but they want to do everything, including what the medical oncologist had to do. And then it leads to bad outcomes still. Yeah. So I think the Pasha Foundation does a lot. Those are foundations that they have been helping a lot of cancer patients in Cameroon. So those are all foundations for us to encourage. But you cannot help one patient at a time. I always told one of my friends, she has a big foundation in the US. She called me one time and she was I'll use the word, she was depressed. She had helped over 20 breast cancer patients and she had no longer have funds. I told her that's not the way to go about it. I'm very sorry. You need to go about it in areas where you can actually make a change. I know it's easy for one person to go online and cry for their help, and then everybody comes to their rescue, because that's the human mind knows how to help one person. But the human mind doesn't know how to help 100 people. If you tell them that 100 people are dying, everybody thinks that their money is not going to help them. So what you need to do is get into where policy is being changed. Advocate at the level of policy, advocate at the level of preventions, big things that can make a huge impact. Education of our young physicians can make an impact in this situation. Education of our nurses. There's going to be someone who will stand up. Even if you're doing something wrong during rounds, someone will put up their hand and ask a question, which may embarrass the person who is doing it, and the person may stop doing it. So by educating the young generation, if you're doing rounds now and you have a patient with breast cancer who comes in, a little mass, and they're rushing in to go do surgery when there's no emergency in doing surgery, a student will ask, what is the ER/PR positive status of this patient? Why are we doing this? If the patient was listening to this lecture. And the attending would have to justify. It may be a right thing to do. The patient cannot afford it. Let's just do the mastectomy, or let's just do this. But you at least someone poke their brain to think about it. That's why we're doing this. In the US, when I found the difference in the US is that when I was rotating at Cornell, I was working with people who discovered trastuzumab. People who discovered, my attendings were there, who discovered the means of doing different types of transplants. I'll tell you this. But when they were talking, we had a patient who had a problem and nobody had ever used artemether. They listened to you who is the junior one. They knew I was the only one who had used artemether and artemisinin in their group, nobody else. They wanted to know the side effects because they wanted to try it. We had tried everything, it was not working. There was data from ACR showing that it works in certain things to prevent graft versus host. They wanted to try it. They had to go back to me. They listened to the whole team. It's a team sport. It's not like, oh, I'm the professor and I know all. No. That's where our change of mentality has to come in. There were Nobel Prize winners in my team who said, oh, Dr. Kenne, you have all these strange ideas. There are times you could have an idea which could be the changing idea. It's not by doing 100 research that you actually change the world, it's by thinking differently from the others. You need just one scientific breaking journal to change the world and think differently from everyone. That's what Watson and Craig did. That's what a lot of scientists have done. The paradigm is easy to follow, but change, you need to think differently. We need to valorize our medical students. Okay, let's move over to the second part of the lecture. We'll try to make it short. The second part of the lecture is we're going to talk about in the metastatic setting, how do we treat these patients? I would always start with a vignette, a clinical vignette. So we do have a 49-year-old female presented with newly diagnosed intraductal carcinoma grade 2, ER 80%, PR 1%, HER2 is normal, so she's ER positive. Clinically has a T3N2 disease, given bone pain. She complained of bone pain. Staging workup was done, which even without bone pain, it had to be done because she was T3N2. Was performed, demonstrated bone lesions. That's very sad. She's just 49. That are biopsied, and they are proven to be metastatic breast cancer. She reports her last menses was 6 months ago, so she is still not defined as being menopausal. She's perimenopausal. In the addition to treatment with biphosphonate, you recommend which of the following? Why is she given biphosphonate? Biphosphonate is an important discussion. Usually for those who have bone pain, who have bony disease, has been shown to reduce mortality. So by placing these patients on Reclast, by placing these patients on Prolia, that's denosumab, and placing these patients, you actually do reduce mortality. It's part of the treatment. What do you give her? The real thing is that we're going to give her here, it's something called ribociclib, which I told you, a CDK4 inhibitor, lestrozole, anastrozole, or tamoxifen, plus groserelin or Lupron. Why? Because we want to suppress the ovaries. That is actually the standard of care. So she's given C. Do we have all of these medications in Cameroon? Can we have them? Yes. I have given them. I have given palbociclib. I have given lestrozole in Cameroon. And Bingo has this. And Bingo has Lupron. Can this woman be treated if she has finance in Cameroon? Yes. So let's not give excuses. It's not chemotherapy that is the solution to our problems. That is a word for all oncologists. It's not chemotherapy. The next thing is, this is just a case of a patient who comes in, newly diagnosed breast cancer also, and she underwent a mastectomy, received anthracycline-based therapy after noticing a bone lesion, and then she gets progression of disease and she's biopsied. She's triple negative. What do you give her next? What do you do? This is a patient I want to send to UB to get me a BRCA test, a genetic testing, okay? Why? Because I have treatment if she is BRCA positive for her. I have treatment, which is the olaparib, the talazoparib that I told you. So D is the right answer. Here, this is a 38-year-old female with strong family history of breast cancer. That tells you a lot. There's family history of breast cancer. And sadly, she presents, so if you look at her here, she presents for treatment recommendations for newly diagnosed breast cancer. Clinically, she has a right-sided T2N3. So you need to do staging workup. Staging studies shows 2 liver lesions. Sad. This is my patient that I actually put here. Several bone lesions. She's a very nice lady. Biopsy of the breast demonstrated invasive ductal carcinoma grade 3, ER 20% positive, PR 5% positive. KI 67 was 45. HER2 knew she was HER2 positive. Just when you read all of these things, it doesn't mean much to you. Liver biopsy confirmed the diagnosis and the HER2 status was the same. What is the treatment that you would recommend to this patient? In the US, I'm going to give her a taxane in combination with trastuzumab and pertuzumab. In Cameroon, because she cannot afford. Pertuzumab just adds the price for nothing. So you just give her taxane combined with trastuzumab. If she can afford pertuzumab, you add it, okay? That's her treatment. Now, let's go over to discussions now. As I told you, metastatic disease continues to be incurable. That's the first thing in breast cancer. If a woman has metastatic disease, it's incurable. But it doesn't mean that they cannot live for long. Despite multiple efficacious agents, all metastatic disease will progress. It remains uncertain what the best treatment choice is. But one thing we have realized in oncology is that the use of immunotherapy has changed the paradigm. We don't say it aloud as oncologists, but there are patients that we have cured with metastatic disease who have with immunotherapy cured. It goes to about 15% to all those who respond to immunotherapy, the groups. So in breast cancer, you can see over time how we have improved. Overall survival has improved with time. Every single decade, we are getting better. Every single decade, we are getting better with what we do. What are the things you should consider? Being an oncologist or an oncology surgeon or a medical student, what are the things you should look at? We need to know, are we going to be prolonging survival? Are we controlling symptoms, minimizing toxicities of the drugs, quality of life? Do not get someone who is 90 years old and start giving them treatment that is going to kill them. I have 90. The strange thing is, in my office, they joke about it. They call me geriatric oncologist. I have one of my colleagues who is a true geriatric oncologist. He jokes about it that Dr. Kenne gave a 99-year-old chemotherapy. I did give a 99-year-old chemotherapy. He walked into my office and he had esophageal cancer, which was metastasized, and had what we called MSI high disease. The strange thing about that 99-year-old is that he's going to die from something else because he had a complete response to immunotherapy. It's amazing what things can be done right now in oncology. So what are the things we look at when we are dealing with these patients? Performance status are very important. Age is a number. Performance status is more important. There are 45-year-olds who come to my office who are obese, cannot walk, whom I cannot even give them some kind of chemotherapy. Now, genetic differences, somatic differences are important. Prior treatments, extent of therapy that they have received, response to the prior treatment, disease-free interval, how long did they stay on hormonal treatment before? How long were they on hormonal treatment before we actually decided to change, or any other treatment? Site and volume of disease. What is their ER/PR status? What is their HER2 status? Get a biopsy. No tissue, no issue. That is the most important thing. There's no tissue, you don't have an issue, even if it's metastatic disease. Now, are all breast cancers the same? Even in the metastatic disease setting, they are not the same, and it's important that we know that. In the metastatic setting, all breast cancers are not the same. So, as I said, hormone positive, HER2 negative breast cancer, 5-year survival was 47%. That has increased. The most recent data, this is old data. The most recent data is almost 60. HER2 positive and ER positive, about 39. If you see here, triple negative has the worst, 17% of patients are going to live. So you should be, this is where we need discovery. A lot has happened. That's not going to be the goal of my presentation. If I'm presenting to medical oncologists, I'll tell them all the nice things that are happening here. Or breast oncologists or surgical oncologists, I'll tell them all the nice things that are happening here. Today, we'll look at the standard of care, but there are wonderful things happening there. Now, what is the paradigm? In metastatic disease, I showed you the paradigm in non-metastatic. It's the same. All patients who are hormone positive get endocrine therapy is the mainstay of treatment, plus targeted therapy. There is even no chemo here, except for those who have visceral disease. Visceral disease is rare. Many Cameroonians have justified to me why they gave chemotherapy in the first place. I had a patient, I called some colleagues whom I know very well. They're like, oh, we gave chemotherapy because it was visceral disease. I looked at it, there's no visceral disease. I said, bone disease is not visceral disease. These are not visceral disease. Stop calling it visceral disease. All HER2 directed therapy in the metastatic setting must get HER2-based therapy. Those who are triple negative, this is the sad part about our studies, is chemotherapy-based. There is not much we can really do for a lot of those patients. And because of that, really, Immunotherapy has come in, targeted therapy is coming. This is where we got a standing ovation in something we called right now, we call it HER2 low, because it increases the pool from just 20% to almost 80% of patients we can treat with trastuzumab deruxtecan, and it got a standing ovation in ASCO 2 years ago. If those who don't know ASCO is the biggest, highest financial motivating conference in the world, please. All specialties taken together. ASCO is the biggest financial innovative conference in the world. ASCO. There is nothing like that. It's an oncology conference. Oncology produces 80% of all data that is published, clinical trials in the world. We take all data that is being published, 80% of them are in oncology. So these are the drugs that we have available for treatment of metastatic disease and the years which they were discovered. The red is for those who are hormone positive, that we use only for hormone positive disease. The green is for HER2 directed therapy. You could take a picture of this. The blue is for triple negative alone. You will realize that the blue for triple negative is only pembrolizumab that shows here. And I'm colorblind also. What is this even? The other one here, this orange here is for everyone who is BRCA positive and has homologous recombinant genetics. And the other ones which are in black is for everyone. This tells you, but there are so many other drugs that I don't have here which are under research. In oncology, there is change in the standard of care every single day. So how do we treat patients? Sequential agents. We have to be able to identify how to give these drugs. Always treat symptoms also. Identify emergencies. If I'm called in the hospital, oh, I have a patient with cancer. That's how they always call me. I have a patient with cancer. The question is it a diagnosed cancer or is not yet? If it's not yet a cancer, it's a mass that you found, please, it's the hospitalist problem, please. No tissue, no issue. Diagnose it, get tissue and all of that, but there are oncological emergencies I must identify. Is there a cord compression? Is this woman having a superior vena cava syndrome? Do I need to do something right now? Is it a leukemia? Is it a diffuse large B-cell lymphoma? Is it a small cell? Those are cancers that need my attention. The other cancers do not need my attention because I need other people to stabilize them. So this is where I lay a lot of emphasis. This is the patient here in Cameroon. This is the patient who has cancer. These are the people who are needed. As a medical oncologist, you should lower your pride and understand that you do need, most of the time, you need a radiation oncologist and their team, the dosimetries, you need the physicists and everyone. You need a surgical oncologist. Most of the time, you can even need them for palliative reasons. If they have metastatic disease, you may want to palliate them. For multiple other forms, you need a nutritionist. There was a good question about nutrition. You need the pharmacist. I cannot function without my pharmacy oncologist. Never. You need physical therapists, you need social workers, you need hospice team. It's just, unfortunately, I cannot function. Like each time I put in a dose, I cannot be going around dose reducing all of this. The pharmacists help me in all of that. They actually call my attention to everything that is going on. There's a lot happening. I see 20 patients a day, and all of them, almost 15 of them are on chemotherapy. Palliative care, you need supportive staff and you need pain specialists. In Cameroon, we have a big problem here, and we have a big problem here. And we have a problem here also. But there's a bigger problem here, and there's a bigger problem here. Training of palliative care doctors, training of palliative care team, training of palliative care nurses. That's where we can actually really use the nurses very well. I cannot function without my palliative care team. If all my patients were calling me for their symptoms, then I'm not going to have a good day. Now, this time around, I'm going to start with the most common, which is the HER2 positive breast cancers. How do we treat them? This is a statement, ASCO statement going out to all oncologists who are scrupulous. Endocrine therapy is the main treatment for every patient who has metastatic ER-positive breast cancer. Chemotherapy only in patients with visceral disease and who need immediate response. And there are few of them. Chemotherapy is never even an emergency most of the time. It's in few cancers, as I told you guys. Diffuse large B-cell lymphoma, things like Burkitt's lymphoma, things like Hodgkin's lymphoma that are growing fast, things like small cell lung cancer. That's it, and acute leukemias. That is the only time you really need to give chemotherapy. Most of these patients do not need it. So don't do this. Justify well before you do it. And everyone needs an ER/PR status first. So what is the first line treatment for ER/PR breast cancer with METs? What should be the first line in Cameroon? What should be the first line in the world? These are the studies. You guys don't need to know the names of these studies. It's called the Paloma 2 trials, the Mona Lisa 2, and the Monarch 3 trials, Monarch 7. These are all the trials. But what did these trials show? These trials came into conclusion one thing. Lestrozole, anastrozole, exemestane, tamoxifen is great if you're living in a third world country and you don't have this other medication. But by adding a CDK4 inhibitor, a drug called palbociclib, ribociclib, and abemaciclib, you do improve mortality in these patients. You do. So the question I asked myself, I found out myself, can I actually give palbociclib in Cameroon? I went through an adventure. I had one of my friends, I have a good collaboration with a lot of Cameroonians, had a patient, breast cancer, metastatic disease. We prescribed lestrozole. He did prescribe lestrozole to her. She's doing fine. The next question was, can we add palbociclib? Could they afford it? And I found out we could add palbociclib. It's the cheapest among all the three. In the US, I'm not going to give palbociclib. I'll tell you guys why. I'll give ribociclib, but I give palbociclib to my elderly patients. But palbociclib was cheap, was available. There was overall improvement in progression-free survival. There is not an overall improvement in overall survival for palbociclib when you add it to an aromatase inhibitor, but there is for ribo and for abemaciclib. That is the standard of care. Here is just me showing you, trying to be fancy, showing you the trials. They are not important, but this is what is important. Look at this graph for those who have done public health. You see the progression-free survivor? You see the difference? This is endocrine therapy alone. Without endocrine therapy, this goes down to like here. Chemotherapy doesn't work even like endocrine therapy, but once you add a CDK4 inhibitor, this is what you get. This is the difference. This is standard of care. What should be done in Cameroon? We should try to get palbociclib and make it generic. That's my take-home message. Abemaciclib and ribociclib may be difficult to make them generic, but if we can, why should we not? India has them. Many countries have them. We should be able to have them. All African countries are not the same. I had my friend whose mother was sick in Nigeria, and we had to get her ribociclib, and she got it. In Nigeria, she got it. They had to import it, but she got it. But it was Pablo, but she wanted the mother to be on ribo. The mother got it, and the mother is alive. Here are just the different trials showing you. In the second line, let's say we have a patient who came in and saw the oncologist in Bingo, Dr. Kuya, gave her some form of anastrozole or lestrozole, and then she progresses. What can we give her? Is there something we can give her in Cameroon? Yes. We have done clinical trials by just switching the anastrozole to fulvestrant and adding palbociclib. This is what happens. In the second line, same thing. If you do abemaciclib and fulvestrant, this is what happens. If you do, this is what happens. So these patients still do not need chemotherapy if you're following me very rightly. That's second line treatment. They don't need chemotherapy. Now, these are the trials showing you exactly what the hazard ratio, for those who understand that, there is improvement. There is improvement in progression-free and overall survival. So second line yet in hormone-positive patients, I'm not giving them chemo. Now, what happens in, these are all the positive trials. What happens in, what should medical students know about this? I always like to keep a slide for them, those who are around here. Medical students, these are drugs you'll be tested if you're writing the USMLE. A lot of you in Boya. Cameroon is just producing doctors now to go and work abroad. That's what it looks like. We are producing so much that so many doctors are not paying them well. So palbociclib, ribociclib, and abemaciclib, what you need to know is that abemaciclib penetrates the blood-brain barrier. So for those with metastatic disease in the brain, that's the best drug. Cytopenias is found in all of them. That's the main thing. You'll be tested as a little resident who is going into this course. Fatigue, all of them do cause fatigue. Nausea and vomiting is abnormal. That makes me right now, I don't, abemaciclib gives me some palpitations. I've had 2 patients who had incredible nausea and vomiting. But you need to test for the QTC for patients who are on ribociclib, because ribociclib prolongs QTC. This is for medical students. Now, what are these trials? Which of them actually improve overall survival? Is those who were on ribociclib, if you see here. Now there's a new study for abemaciclib increasing overall survival. This is the goal. That is why I prioritize ribociclib. But if you're living in Cameroon and you have a patient who has hormone receptor positive metastatic disease, surgery does not improve survival. Stop trying to take out the breast. Point number 1. Radiation does not improve survival unless you're radiating an area where they have a cord compression, bone pain, or some kind of pain. That's where you can help them. Palliative radiation. You should give them palliative hormonal therapy. You can give them anastrozole, letrozole, exemestane, or tamoxifen. You can add palbociclib, ribociclib, or abemaciclib. If they can afford it, that should be your standard of care. Please. So for CDK4 inhibitors, in summary, what you should know is that it's important that all of them will require a CBC that you monitor the account. You need to do EKGs right now. And you need to consider diarrhea as one of the biggest side effects for those who are going to be on abemaciclib. Now, let's say third-line treatment. Let's continue. Third-line treatment. These patients have had anastrozole in Cameroon. They have had palbociclib plus fulvestrant, which is all found in Cameroon. What do you do with them in the third line? These are the clinical trials. This is where it becomes complicated. Why? Because we need an NGS. We need to know if they have a PIK3 kinase inhibitor. If they do have this here, you could offer them apelacib or cabazavir. These are drugs you can offer, but there is everolimus. You don't need anything. This is an mTOR inhibitor. Everolimus is something you can give them based on the Bolero trial. But this becomes now real oncology. I don't want to disturb you guys with it. So there are multiple other treatments that you can give. If this does not work, there are patients who can also get elacestrant. This is a new drug. It's not found in Cameroon. But you should know about it. It was compared to fulvestrant and anastrozole, and it beat it. So there are things that can be done. Going back to what we discussed that Boya can help us with, can we get genetic testing done in these patients? If they have a BRCA mutation in the third and fourth line, you can actually give them a PARP inhibitor. That is approved, and here is data for it. Here is the thing that changed oncology forever. This drug alone single-handedly changed oncology. This drug changed breast oncology, let me put it that way. Now there is a debate on what we should do, what is actually HER2, what is actually this. This drug is called trastuzumab deruxtecan. It's an antibody drug conjugate. These are the new drugs that we have in oncology. So what is an antibody drug conjugate? For all those who are here, I'll just take opportunity to actually explain what an antibody drug conjugate is so that those who are here can understand it. So chemotherapy, it's like sending out a ballistic mixer. You have no knowledge. It's just going to go in and bomb people. That's what chemotherapy is. It has no sense. It makes no sense. You just send it out. It goes there, it throws a bomb, and it bombs everybody. Targeted therapy is a sniper who is able to shoot and snipe and kill the people that he wants to kill. Antibody drug conjugate is actually a targeted bomb that can go around. You can send it. What it does is that it's able to target areas which are hard to, and it releases the bomb only there. That is what we call targeted therapy, and that is the way forward in oncology. We have multiple other targeted therapies that are being developed. Trastuzumab deruxtecan was one of the ones that changed oncology forever. Why? We provided trastuzumab to every patient who was HER2 positive. But we realized that those who were HER2 low, meaning that those who had HER2, which was 2+, 1+, could also respond to this drug. And we can now use it for a lot of patients. So this was called the Destiny 04 trial for those who are having hormone receptor positive. And now you could see before, this is why this got a standing ovation in 2022 ASCO. Before, HER2 was made up only 20% of breast cancer. The rest of them were considered HER2 negative. Now, if you understand IHC testing, this is what we talked about yesterday. That's going to be one of my biggest advocacies in Cameroon. If you understand IHC testing is a grading method where those who are IHC 0, those who are IHC HER2 1+, those who are HER2 2+, these two groups do not respond to HER-directed therapy before. So these are groups that we neglect, but a majority of all our cancers fall here. Now, once we take into consideration HER2 low, this increases the number of patients who have HER2 disease from this to almost 70%, and this 70% becomes eligible for particular treatments. And what is that drug? That drug is called trastuzumab deruxtecan. This drug revolutionized breast cancer, both in triple-negative breast cancer, because those we used to call triple-negative, a lot of them are HER2 low, and even in hormone-positive breast cancer, where we had done everything, we could provide them treatment that actually works and improves overall survival. So this got a standing ovation in ASCO. If you get a standing ovation in ASCO, it's equivalent to, and they won a Nobel Prize for this, it's equivalent to winning a Nobel Prize, okay, for what you have done. This is outstanding, and those who discovered antibody drug conjugate technology got a Nobel Prize. So that is just telling you exactly how this has changed oncology. It has led to new drugs, other drugs which are targeting other places. This is a TROP2 inhibitor. I will not talk much about it. It's just here, it's sacituzumab govitecan that you can use next if these patients progress, those who are ER positive, and there is a positivity. So this is really what I want to drive across as a message. Not all, we are talking now about metastatic ER positive breast cancer. Not all metastatic ER positive breast cancers are the same. There are those who are highly sensitive in the extremes here, and there are those who are just likely resistant even from the beginning. You need to know how your patient looks like. I have a patient who has been on anastrozole with metastatic disease. She is not my original patient, but I'm seeing her follow up 10 years, no disease progression, 10 years out. That I can tell you, she comes to my office 10 years out only on anastrozole. I have a lot for her in the future, but there is a difference in these patients. There's somebody you're going to put on anastrozole 2 years, 6 months, they'll progress. So how does the algorithm look like? I always love to summarize at the end, if you're just coming in, what you should take home. First line treatment in the rest of the world should be hormone receptor and aromatase inhibitor hormonal therapy, which is anastrozole, letrozole, exemestane, and the tamoxifen, plus a CDK4 inhibitor for those who are ER positive in the metastatic setting. If you don't have this, just give them this, please. Second line, you should consider giving them another hormonal therapy. Third line, you should do your somatic mutation testing, and Boya can help us with this. In the third line, patients who have ESR1 mutation, they can get elezestran. Those who have PIK3 mutations can get apalacid. Those who have PIK3 or AKT or P10 mutations can get apavacib. These are all treatments. Then, if they progress after that, do you give them capecitabine at this level? I do not. I do my HER2 level and I give them trastuzumab deruxtecan. That's what I do now. Next, I do sacituzumab govitecan, then I come to capecitabine. That is actually how I treat these patients. These things, this slide is important to know. This is detailed oncology, but it's just important for us to know that we can do a lot for these patients. Here is a summary slide. You can take a picture of it. For the sake of time, let's move over to HER2 patients. Let's say you have metastatic disease already, your HER2. Here are the different receptors. There are multiple receptors. This is a very intrinsic concept in oncology. I'm fascinated about it, but I'll not spend much time. 15 to 20% of your patients have HER2-directed disease. So these tumors express several things. There is HER1, HER2, HER3, HER4, these are all receptors we're trying to target. But those who don't know, HER1 is actually EGFR mutation, which is it's a big, nice discussion when we come to lung cancer. My specialty is lung cancer, so I love talking about lungs. But today I'm talking about breast. Now, there are so many, this used to be the most deadly cancers in oncology. In breast oncology, let me put it this way, not all of oncology, in breast oncology, but some amazing scientists back in the 1990s discovered trastuzumab first, and this was tested and has revolutionized this cancer forever. You do have drugs like trastuzumab, pertuzumab, mogamulizumab. You have lapatinib. These are TKIs now. Naratinib and tocatinib. You do have now antibody drug conjugates like trastuzumab deruxtecan. You do have TDM1 like trastuzumab extendi. These are all drugs that are important that would help you. It's good for us to know. The Cleopatra trial, this is one trial. This is the only thing the GPs will be tested on. Those who are coming to the US, want to move to the US or in UK, you'll be tested to understand that by adding trastuzumab to normal chemotherapy, you improve survival. And that has become the standard of care. This was what happened. This became the standard of care. That's what we call the Cleopatra trials. And overall survival got better. So first-line treatment, I am in Bingo, or I am in Douala and I receive a woman. Sadly, she has metastatic disease. Or she has had treatment before and I want to treat her. What should I give her? Do we have docetaxel? Yes. Do we have trastuzumab? Yes. Do we have pertuzumab? Yes. That's the standard of care. Can she afford pertuzumab? Maybe no. Let's give docetaxel and trastuzumab, please. If she cannot afford it. You don't want people to get bankrupt just trying to kill themselves. Usually we give trastuzumab and docetaxel for 6 to 8 cycles, then we continue just with trastuzumab. This is very, very expensive on the patient. And this is something we need to advocate for the government to actually have trastuzumab in their essential drug list. Now, which is the big guy? This same drug I called trastuzumab extendi became standard of care when compared in the second line. This was the standard of care before. After you have given trastuzumab deruxtecan, you could give this one. It became the standard of care. Then, as things will go, there was another trial called the Klein trial, which combined certain 3 drugs. It was trastuzumab, tucatinib, and capecitabine. This was the second-line treatment that beat our initial second-line treatment and became standard of care. This regimen is good because it penetrates the brain very well because of the tucatinib. And now this is actually third-line treatment. It's no longer second-line. Why is it third-line treatment? Is because of this trial. If you've heard me today, I've told you there is this drug, trastuzumab deruxtecan. It redefined breast oncology, is defining many other cancers. Gastric cancer is also being used there. Lung cancer is being used in lung. It has a tumor agnostic approval. For those who know what tumor agnostic approval, not many drugs have a tumor agnostic approval. It means that no matter the cancer, if you're HER2 positive in that cancer, you could get trastuzumab deruxtecan. That's what it really means. Pembrolizumab has a tumor agnostic approval if you're MSI high, meaning that you have microsatellite instability high, or you have tumor mutation burden, which is high, you could get pembrolizumab as first line no matter the cancer. So trastuzumab deruxtecan, no matter the cancer, you can get it. Is this drug available in Cameroon? The answer is no. Can we get it? Yes. Can we get it from India if you're rich? Yes. And should we be advocating to get it? The answer is yes. So this has defined and changed breast oncology forever and has changed the way we see breast cancer patients who are HER2 positive and those who are HER2 low. So our take-home message really for HER2 positive breast cancer is that first line is available in Cameroon, docetaxel, pertuzumab, and trastuzumab, but it's not affordable. It's available, but not affordable. And in the case where you cannot add pertuzumab, you should give them trastuzumab and docetaxel as first line. Second line treatment, trastuzumab deruxtecan is not available. If this was an oncology lecture, we'll talk a lot more about the lung toxicities. And then in the third line, there are many other options which are not available. But We should know about them. Our students should know about them so that in the future they can advocate to get it. Beyond HER2, what is going on? There are just so many other options I'm not going to talk about today because this is not, in the fourth line, I don't want to get you guys to fourth line, fifth line, sixth line treatments. Those are not things that we should be talking about here. But what I want all of us to know is that we need to know the HER2 status. It's a crime not to know it. It's a crime not to know the hormonal status. New therapies have changed the natural history of HER2 therapy of cancers. We have drugs that work. Oncology, in the first time, I think it's in 2000 that we started seeing that we are actually helping patients as medical oncologists. Now, the last part of our lecture is going to be triple-negative breast cancer. This is the saddest part of the lecture. It's the last part. Now, I'm taking away all the other drugs. These are the things we are left with in triple-negative breast cancer. We don't have much. We have single-agent chemotherapies. Then we have pembrolizumab, we have trastuzumab deruxtecan, we have sacituzumab, and we have other things. What is very interesting in triple-negative breast cancer has been that anthracycline and taxanes were often considered first-line agents, but now are used increasingly in the neoadjuvant setting. From what I showed you before, there is no evidence that precise sequencing of therapy affects overall survival. We really don't, we just use one chemotherapy after the other. Response rates are more influenced by line of therapy than the therapy you use. Treatment decisions should be individualized based on the patient in front of you. What is the standard of care? The standard of care, usually I do provide patients either taxane-based therapy, anthracycline-based therapy. There are other therapies that we could give. Right now, I use gemcitabine and carbo, and you need to know if they are BRCA positive. You need to also do new molecular testings, which we don't have available in Cameroon. Here is the first study that gave us a bit of light in the tunnel. It's called the Impassion 103. Impassions are usually studies for atezolizumab. Anytime you're using atezolizumab, the studies are called Impassion. When you're using Keytruda or pembrolizumab, they are called Keynote. When you're using nivolumab, they are called Checkmate. So that's how, if you want to really decipher how the oncology world thinks, they're using all these words to make you guys, to frighten people not to come into oncology. The FDA withdrew the approval they had for this drug, which was sad. It was a sad day for oncology. But the Keynote 3522 combined Keytruda and chemotherapy for those who have a combined positive score greater than 10. That's what we call a CPS score, means they can actually respond to immunotherapy. This is just about 40% of triple-negative breast cancer. This made a difference. So in this group of patients right now, we do give them chemotherapy and immunotherapy in the metastatic setting. And this is not the majority of our patients, sadly. So triple-negative is one of the fields where we still have a lot to do. We have 40% of them who qualify to get immunotherapy. Here is the overall survival benefits that you do have. And this is only approved for a CPS score greater than 10. We cannot even do CPS scores in Cameroon, and just 40% of patients are actually PD-L1 positive. This is sad, but these patients do benefit from immunotherapy. But the clinical trial actually did show that patients with greater than 1% CPS score benefit. So in some places in Asia, it is actually approved. In the US, it's approved just for 10 and greater. In Asia, it's approved for 1. For Europe, it's approved for 10 and greater. Now there are new drugs. This is where medicine is exploding in the triple-negative breast cancer setting. There are new drugs coming. They are antibody-drug conjugates. This is the nicest part of oncology. They are targeted weapons. These are your drone attacks, where you can send a drone. I'm just giving it in warfare, and it goes and bombs a specific house where Saddam Hussein may have been there. This is sacituzumab govitecan. It's a trope inhibitor. You attach chemotherapy to antibody-drug conjugate. You attack chemotherapy to them. Chemotherapy that could not be, the body could not survive them normally. And then you attach them to antibodies and you give them. The antibodies go to the cells where you have cancer and they attach to it and the chemotherapy is released. That's how they work. They are amazing drugs. There are multiple of them. I've just put in 2 of them here. There is trastuzumab deruxtecan, same thing. This is the drug here. This is the trastuzumab here. And here, this is the deruxtecans that are here, which is a topoisomerase. They go in, they look for trastuzumab. Even if you have 1% of trastuzumab, they go there, they look for it. There's what we call the driver effect. If you're sending a bomb, let me just take a bus driver who is driving a bomb. Who's driving a bus, and you want to do, there are terrorists in that bus. And there are also some terrorists outside. You send a bomb where you're going to kill the driver. When you're killing only the driver, is trastuzumab. When you're killing the driver and all the passengers, is actually you're using trastuzumab deruxtecan, and the bystanders were terrorists. That's how the trastuzumab deruxtecan works. And here in triple negative, we have gone to see that it works with patients who have HER2 low. And that's why it's important to know about the concept of HER2 low. So in conclusion, today, we're going to conclude very soon. In conclusion, we see that the saddest part of oncology is still triple negative breast cancer. Single agents, unless need rapid response, is still where we start. Take into consideration previous therapies. No clear sequence is existing right now. These are the drugs you can give them the way you like in the first line. If we need to do specific testing, first line, if their PD-L1 is greater than 10% in the US, you can give pembrolizumab. There is a big difference. In Europe, 10%. In Asia, 1%, they agree for you to give pembrolizumab in China. You could do olaparib or talazoparib if they are BRCA positive. A lot of triple negative patients are BRCA positive, and they do gain from this drug. Then we have the new guys in the block. They have been used in the third, fourth line, but some of them are more effective in the third line than even first line treatment. That's the amazing part about it. Like sacituzumab govitecan is super effective and at times better than the first line drug that you gave these patients. At times, these patients had just 6 months in the first line, but you gave them sacituzumab govitecan, they had about 2 years. After they progress on sacituzumab govitecan or trastuzumab govitecan, you can reverse the order. This is what we do. There are multiple other drugs that I don't have. For those who are oncologists, this slide is for you. You can take a picture of this slide, have it at home, use it. I'm not going to bore those who are non-oncologists here. Our last slide is bone reabsorption agent. If you have metastatic disease to the bone, prostate cancer, breast cancer, any cancer, you do benefit from biphosphonate. Alendronate is found in Cameroon. You're given weekly. Protect their bones, please. And send them to the dentist to make sure that they don't have any dental caries. You can use your rank ligand inhibitors. That's denosumab is also given in these patients. And in the US, I give zoledronic acid most of the time. I don't do alendronic acid just because I want to give them a shot once a year or once every 6 months. I also do use denosumab, which is called Exchiva or Prolia. You can give it, it's called found in Cameroon. So in conclusion, metastatic breast cancer is incurable. It's available in Cameroon. There are better therapies. Patients are living longer. Oligometastatic disease is a very complex topic, deciding what to do. As I told you guys about my patient, where she was young, came in with oligometastatic disease to the lungs. I treated her. She had a complete response. She was given Keytruda, pembrolizumab, and gemcitabine and cabo. And then I sent her to the breast surgeon. The breast surgeon did a double mastectomy. Then we placed her on palbociclib maintenance, and she's alive. She's now 2 years, no disease. And she may be a miracle in that sense. If she has reoccurrence in the lungs, I'm going to radiate it. So you do see, know your ER, PR, and HER2 status. It's criminal not to know it. That's the take-home message, please. It's criminal, even in Cameroon. It can be done. Don't give them chemotherapy without knowing that. Treatment according to subtypes, sequential agents, think about previous treatment toxicities and the menopausal status. Treat symptoms and recognize emergencies. Consider bone agents in those with metastatic disease to the bones. Breast and prostate, which are the most common cancers in Cameroon. In men is prostate, in women is breast. They love the bones. So we are coming to the end. difficult roads can lead to beautiful destinations. That's what I think always. Even back home in Cameroon, I think we are very intelligent people. I don't want to override our ego, but we're very intelligent people. And at the end of all this, I think Cameroon has a better future. We should just train the young ones better and make them to have a sense of responsibility and to give back to their community. So thank you. We could have like 30 minutes of discussion. You can unmute yourself and then let's talk. And usually there was another topic I had to give, but I'm not going to give it. It's called the spatial situations of breast cancer. I think we've talked a lot about different things now. And please, if you can just unmute yourself if you have questions. I see a lot of feedbacks coming in from the chat. So please, those who have contributions, if you wrote something in the chat, you can unmute yourself. We are done for the series. The only hope I wished is that we had more medical students join us and be part of this presentation. If at the end, I would love to hear a word from Professor Waleji and also from the Dean, Professor Hale, but those who want to unmute themselves, you can unmute yourself. If you have anything that you think we should talk about, you don't even need to raise your hand, just unmute. Are there any questions? Why is everyone so quiet?
Hello, Doctor. Good evening.
Yes, please, I can hear you. Just introduce yourself a little bit for us, and then you can ask your question.
Everyone is quiet. Can I say something?
Yes, Professor Tambe, I can hear you, but your line is a bit the audio is having a problem.
Yeah, my lines are shaky. Can you hear me now?
Yes.
All right. I'll just ask two very brief questions. My very first question is, all the studies you have presented on the different medications are using different endpoints, such as progression-free survival, disease-free survival, and the overall survival. And that is accepted for clinical trials. In your clinical experience, what do you do to determine complete response, disease progression, stable disease?
Yeah, very, very important question. So once
how do you do it? It's good for us.
Very important question. In oncology, when we talk about complete response, is most of the time is radiological imaging, where there was disease and right now there is no evidence of disease at the moment. Yes. So there is no evidence.
Used to be able, these drugs have been,
oh, Dr. Tambe, today we are not getting you very well.
So I need to know the metric you use to be able to conclude that the patient has.
Well, I was unable to get Joshua's questions completely, but there is a RECIST criteria. There are criteria where you use in order to, in clinical trials, there are two boards. There is usually the clinical trial actually has a board that actually evaluates these patients, and there is an outside board that comes in order to supervise their data. I'll just make it that way. And each trial has an endpoint. The ultimate endpoint is overall survivor. You cannot beat overall survivor. A lot of trials either have overall survivor as their primary endpoint, when they're scared to have that as a primary endpoint in diseases where you cannot tell that overall survival is really a big thing. But in oncology, most of our clinical trials are actually overall survival. But if you're scared that overall survival, a lot of them use progression-free survival because there are times when the second line and third line treatment are as good, and substituting them may skew the overall survival. So progression-free survival can be a good surrogate marker. So depending on what clinical trial you're dealing with, but the ultimate clinical trial and the ultimate result is actually overall survival. Once you have an overall survival benefit, the drug works. It means that no matter the lines of treatment that you're giving these patients, there is an improvement in survival. So that's our ultimate measure. In all these trials that I've given you, talking from ER disease right up to, let's talk about the ER disease itself. All those trials in the first line showed that aromatase inhibitors improve overall survival by a big difference compared to chemotherapy. Those trials also show that by adding ribociclib, palbociclib, and abemaciclib, you improve progression-free survival. But for abemaciclib and ribociclib, you improve overall survival. Pablo did not meet his endpoints. There is a whole debate about it. That's what Joshua is bringing up. There are so many kinds of debates when you start doing research, and you are, my public health specialization was in clinical trials. So there are other things that comes in place when you're looking at those things. Let me give an example. I just told you guys right now, in triple-negative breast cancer, first-line treatment is single-agent chemotherapy. Second-line treatment is trastuzumab deruxtecan. We have not yet, we are still doing trastuzumab deruxtecan clinical trial in the first line, but what we are seeing, and sacituzumab govitecan, is that patients are living longer in the second line compared to the first line. So if you're doing a clinical trial, let's say in the third line now, comparing medications, you may not even see an overall survival, or you could not see an overall survival in the first line because in the second line is skewing the first line treatments, because those patients later on go into a second line and get a better treatment. So you could see that differences in progression-free survival, but because the second line treatment may be better than the first line, we've seen that continuously in medicine. In Hodgkin's lymphoma, it took us 50 years to change the standard of care. The standard of care in Hodgkin's lymphoma is either Bierkopp in Europe, in Germany, or what we call ABVD. It took us 50 years to beat ABVD. And do you know what beat ABVD is? Adding nivolumab to AVD. We could not beat that regimen because already survival was like 90%, but by adding immunotherapy, and that's why in subsequent trials, you could not see an overall progression-free, you could not see an overall survival, but right now we have trials that you can see that. There are multiple clinical trials like that where first-line treatment is so good that in the second line, our subsequent treatments are so good that if you're trying to get an overall survival, you may not be able to get it, but you can actually see that in terms of progression-free survival, because of other subsequent trials, treatments that are good, you're unable to get that. But that's a whole big debate. But in the clinic, if I understood Professor Tambe's question, it's just that he was being cut off. In the clinic, how do I know? It's very easy. So I have a patient. Most patients can have complete response, partial response, or progression of disease, or stable disease. Stable disease is response. Let's take a cancer like triple-negative breast cancer. You come in with bone meds, you have disease in the lungs and everything, and I give you chemotherapy and immunotherapy. When I say there is complete response, there is no evidence of disease on the scans. But there is a RECIST criteria that is being used to define some of those things. The second thing is that if there is partial response, they use the RECIST criteria to tell me which lesions are progressing and which ones are not, or which ones are staying stable. If there is stable disease, there is no new cancer developing, no new disease. That's why interpreting an oncology imaging is completely different by just doing radiology sitting. Radiology needs to actually compare. That's why I tell you, you have to provide data, and garbage in, garbage out. You need to tell the radiologist, this is what I'm looking for the radiologist to tell you what you're dealing with. So that's what I deal with every day. My patients are either having complete response, stable disease, or they are progressing.
Thank you, Munoh. That classification is from actually the racist 1.1. And I actually do racist. And but unfortunately, a lot of some physicians don't use the racist criteria to be able to assess response, which is very tedious to be able to do, because you must have a baseline scan, or you must have subsequent studies to be able to come out with a full classification of complete response, partial response, progressive disease, or stable disease. But then in your presentation on the multidisciplinary imaging was completely left out. I'm sure that was an omission.
That was an omission, and I would want to correct myself with this very well, because in the US it's completely different, because those who interpret oncology images must use the racist criteria. It's not like a regular images. I want to get what is happening to the patient. And especially in cancers that are solid malignancy, there are other cancers that are non-solid malignancy that we use other criteria to check for response, like leukemias. But you must—
the Lugano and the Choi criteria.
Yes, you must mandatorily use a racist criteria. It's mandatory. So that's something, if I'm getting an image from the radiologist and they don't tell me that, and the radiologist and the pathologist are a pivotal and important member of the oncology team. I'll tell you what I told Lacantini. I attended Lacantini's tumor board once. Not once, multiple times. I had my junior who was there, who was a pathologist. He locked me in. I was so embarrassed because in the tumor board, the pathologists did not present, but their job was to ask questions. In the tumor board, the two most important people are the radiologists and the pathologists. Actually, the two most important people. Why? The pathology, if I'm bringing a case to the tumor board, pathology, a lot of students who have never done pathology think pathology is an exact science. It's not. It's like a clinical science that you do. You're also trying to figure out things. There are times they are wrong, 20% of the time. There are times they don't even know what's going on. And they need to also answer their part. If I'm bringing a case to the tumor board, I may have a question for radiology and I may have a question for pathology. I have questions for radiologists all the time, even concerning the racist criteria. Is my patient truly progressing, or what the hell are you talking about? It's not like I'm coming to challenge them, but I want all the radiologists there to review the imaging before talk to their department, because it's a hard thing to do. They actually, each time in my hospital, we have tumor boards for every cancer. And then we have a general tumor board from Mondays to Fridays, depending if you have a patient. We have a colorectal tumor board. We have a breast tumor board. We present 20 patients every single week. In that tumor board, the people who are key is that—
I want to get
Oh, Professor, I'm listening. So the people who are key are the radiologists. How does the tumor board work? The radiologist presents the imaging, presents the biopsy, presents the stage. We are able to stage it image-wise. The pathologist presents the pathology report. If it's a lobular carcinoma and doesn't make sense to me, and he's telling me that it's ER/PR negative, I don't think it makes sense. I provide details about the clinical situation. I've had a patient who had an axillary mass, biopsied. They told me it was a rare kind of cancer, a rare form of sarcoma. I did not believe it. This guy has had multiple melanomas that were resected, and I thought this was a melanoma. We sent it in a second opinion to Mayo Clinic, came back still as sarcoma. We sent for a third opinion in Johns Hopkins. They said it was a melanoma. And that tells you how much these sciences can be complex. They are not the way people look at it. I have had my patient who comes in, I'm giving him Keytruda. It's working everywhere. The radiologist tells me that there is one lesion which is progressing. He doesn't know his racist criteria. I bring it up to the tumor board, and because I want to decide, should I stop Keytruda, which is controlling all the lesions except for that one, or should I radiate it? So these are very important decisions, and Professor Tambe is bringing up a very important thing. Even back home in our training, if we start treating cancer patients, we need to understand the role of everybody. We need to understand how we're going to train our radiologists to read the imagings properly. It's not going to serve us any good if imagings are not read properly. The medical oncologist will not even know what's going on. So 80% of my cases— okay, so Joshua, I'll add one thing, how I know about disease responding now in the US. It's a bit complex. It's getting very complex. So in the US, Nader is going to tell you, I do use circulating tumor DNAs now. So I'm able to see, even when you don't have disease, I can see when you have one cell of cancer circulating in your blood, but that's not something I'm talking about today. I use circulating tumor DNA to see when disease is coming back, when the images cannot even predict it. Meaning that I treat you for cancer, I test for your circulating tumor DNA, it goes to 0, and I monitor it every 3 months as I'm doing imaging. If your circulating tumor DNA starts coming up and your imaging is not showing anything, you're progressing. That's one way. I do, in these patients, imaging, most of the time is PET scan, depending on the recommendations. And depending on the kind of cancer, there are other things that we do look at. But these are just some of the things that we do. But right now, all my patients whom are in the neoadjuvant, especially breast, colon cancer, get circulating tumor DNA from me. They do get circulating tumor DNA. All my patients get circulating tumor DNA. All my patients get NGS to look for other mutations. There is just some amazing things happening in oncology. For the young generation, I'll tell you, there is no field like oncology at the moment. We are at the pinnacle of science. The others will join us soon, but we are at the top of where science should be.
That's great. I like that. Just some of the few challenges I have when I do RACIST for tumor oncology CTs is the fact that we don't have, we have very few dedicated centers. And we always have the problem of physicians requesting follow-up scans. You never get the previous scans, so you can't actually compare. And secondly, even if you have a previous scan, we didn't have a baseline RACIST classification. So there are no target lesions, there are no non-target lesions, and we cannot even tell if a particular finding is a new lesion, because a new lesion at any given point in time is going to be disease progression, irrespective of the size of the other lesions that were measured. So we have a patient who will do multiple studies from multiple centers, and you neither have a quantitative tool to be able to determine treatment response, and even the qualitative RACIST assessment you really can't do. So it's a very big challenge. And again, the way most of referring physicians do requests for scans, be it initial baseline scans or after or during treatment, or maybe after complete cycle of chemo or radiation therapy, most of the time I'm at a loss. I don't know where I am. I don't know how to report the scan. I really don't know what information is needed at a given point in time. But again, as I said, the more we learn, the more other people get on board to really know how these things function. I think we'll be getting better when it comes to doing oncology. Whether we like it or not, oncology is the medicine of the future, and we all have to get on board. Thank you very much, Munoh.
Yeah, thank you for raising an important point. The reason this point is so important, even in the US, we have this problem, so we have found solutions where patients get scans done all over the place before a radiologist, because in the US, general radiologists, they are oncology radiologists, they are brain radiologists, they know where they want to sit. A lot of people don't want to do onco radiology interpretations. They hate it. But the radiologist does not interpret the imaging if they don't have the formal imaging. They do not. They interpret the imaging, they request for the formal imaging, and they do have a system now in place, which is kind of mandated, which is the PAC system. They can share information. And in different softwares, they actually request for the formal imaging if you're going to a new place, but we try to maintain it done in the same center where you did it, if it's a healthcare system. But in the US too, it can be complex. So that's why if someone interprets me an imaging without comparing it to the previous imaging, I take it to the tumor board. Clearly, I take the case to the tumor board, because what do you want me to do? Unless you're going to describe me a new lesion, as you just said, which was not there before, I know there's progression. If there's oligometastatic progression, I want to know what to do. But if you are not comparing it to the previous imaging, in the UK, they don't have that problem much because they have a unified system. In Germany, the same. In the US, we have fragmented systems. Some people use Epic, others use Senna, others use Meditech, others use everything. Everyone is using everything, trust me, in the US. But there is now mandation in certain states where they collaborate data and they are able to interpret. So the radiologists themselves, as you said, which is a big problem in Cameroon, and those who are prescribing need to know about this problem. That's why we're here. The radiologist, for them to do a good job, they need to see and know what the other image was, the prior image, before making conclusions. I think Professor Walaji was unmuted and wanted to say something, but we can't hear him. We are not able to hear you, Prof. So I don't know, anyone else has any contribution before I want to hear a word from Professor Hale, Professor Walaji. If you guys want to have something to say, you can unmute yourself. We're almost getting to the end. If you, just that I can't hear you, Prof. Walaji. Dr. Nadej, you have something to add from the surgical oncology standpoint? We're done with our training, so.
So first of all, this was probably one of the best lectures I've had on this topic. To be honest, I learned a lot. I just want to say that even better still than oncology, surgical oncology. So if anybody's interested, we can chat. I was very curious about whether or not there was really capacity in Buea or in Cameroon to actually do molecular profiling. So this is something that I did during my research time at Hopkins. And I was working in lung cancer, right? And I think that's what started my interest in looking into cancer in our population. What we were able to do, I was working with RNA molecules. But essentially what we discovered is that the tumor microenvironment is different in Black and in African than it is in Caucasian. So we know that is true for a lot of diseases, not just lung cancer. We know that, you know, close to 30% of colon cancer in sub-Saharan Africa is MSI high, right? We know that, you know, 30% of sub-Saharan Africans with breast cancer is triple negative. If really there is capacity, if there are researchers already working with that, I think that there could be an area. This would be a very interesting area for us all to explore and to invest in, because you cannot argue with data. And I think the main thing, we all come back to all of this, right? All of the public health experts, all of the basic scientists, as myself, come back to this. We don't have the data. We don't have the data because we're not studying our population. How do we try to move this forward? Who are the people we need to talk to? How can we change this if we, you know, if we really are not investing in understanding the disease in our people? So that is the question that, you know, as we go through these lectures, absolutely brilliant lecture, I have to say. This is truly a CME. Like this is something that somebody, you know, I took so many screenshots. But at the core of it, should we not kind of try to look back at exactly understanding disease in our people?
Yeah, that's a very important question. And I'm happy we have a lot of professors here. Unfortunately, Professor Walaji cannot talk. I don't know what's happening with his mic, but that's our goal. If we have researchers like yourself, I know very well, you do a lot of research. Researchers like yourself, there are multiple other Cameroonians. I'm not involved in a lot of research in the US who do have NIH grants. There's Professor Alan Tita who has grants and is working with University of Yaoundé and Boya. There are others who have grants. There's Jay Bazi who has grants, who is a gastroenterologist. He's my classmate, and he's at Yale and has a lot of grants. He's working with CSU now. We should collaborate. There is Professor Hale who is here. We should collaborate in answering these questions. Professor Joshua Tambe, he's my classmate. He's a radiologist and he has a PhD in public health research. And those are people we can collaborate with. We need to know the capacity of what is happening in Boya. I know with COVID, they do have a lot of next generation. They do have, some of the professors there have next generation machines that they are using for different tropical disease research. And they're doing NGS over there that I know very well, but I don't know the capacity. A lot of them do have PCR machines. PCR machines are they are everywhere in Cameroon. I was a clinical pathologist in Cameroon, so I could call people. I can call Professor Leke. I can call my attendings with whom I worked with. PCR is available. You have a lot of people who can do certain tests. You know, these things are in different levels. My specialty too is lung. So what took me into lung oncology is the fascination about it. They know in my office how fascinated about it. There is no better oncology department than lung. In lung is so fascinating that you're able to do miracles. Like I do miracles. I can tell you that many people here will not understand, but I do miracles on patients. I have patients where I'm able to play with EGFR exon 20, exon 19, exon 18. They have a resistance. I do another NGS. It comes out resistant in MET. It's just the way oncology should be practiced in the future. And it's going to be very funny that we are light years away from that. But what we do, that's really what took me into oncology. What took me into lung oncology is the amazing things you can do, where the other fields are actually still catching up like breast. But oncology in lung is something amazing. Now we're giving CAR T cells, we're giving bispecific to those with small cell recently. And I just had one with that CRS in the hospital I was called before this. So it's amazing. The question is, how do we get people in Boya? I don't know those who are the researchers. I know people like Professor Mbacham used to do a lot of research, Professor Rose Leke. Those are all others, but there are young generation professors in Boya who have really good NIH grants and who have other grants going on. We need to liaise with them. And I think Professor Tambe can help us figure out for the town hall, those who are doing what and what they're doing, and how we can adapt and how the diaspora can collaborate with those people to get these answers that you're talking about. Really, it is very important. And we're hoping that you can also collaborate with a lot of them once you get your new position and start. And also help with teaching back home. Because really, we have a lot of surgeons, but few of them are trained in oncology surgery. You know the difference. It's just the same thing like where I work in, I used to work in New York City. We had multiple centers that could do pancreatobiliary surgery. Now in Albuquerque, it's only UNM. We have two great surgeons there, but you know how it works. We want to keep just two of them. Presbyterian should not get, because we want them to be busy. The more you do the surgeries, the better you have a team, the lower the mortality. That has been proven. So we really are striving for that.
I'm available, you know, whenever, and especially when it comes to teaching. Like I said, if we have a sense of what the need is, what procedures maybe most beneficial. I have I have colleagues that are really interested as well. So I think that it's a matter of all of us coming together and trying to brainstorm as to what is the best way to go forward. But I'm available anytime.
Yeah, I think the first thing we're going to do is trying to do a need assessment. As I think we discussed offline, do a need assessment. We should also try to do not only need and do resource assessment, who does what and who is capable of doing what in Cameroon. And once we know that, we create a library, a kind of a reference where everybody knows, okay, the other day I had a patient in Boya who had a lung mass. The question I needed to know, who can safely do a bronchoscopy given the position where it was? Who could safely do an e-bus for that patient? And I did not know, and I know Cameroon very well. I have multiple colleagues that I talk to who could safely do that to get us even a biopsy. That was the real problem. Even if it's the location is found maybe peripherally or more to the anterior, who can do a biopsy safely also? Who can do a biopsy safely? If you want an IR, who is the IR who is there who can do biopsy safely? Who is the pulmonologist? Who is the cardiothoracic surgeon? What do we need to do going forward? So those are all things that come at times, but you get to realize that even the doctors themselves back home do not know. And I'm sure with the level of how Cameroonians are educated, there must be someone who is doing it. The question is, we don't know the right person. During COVID, I learned about people who were intubating and those who were doing different things and hospitals that could do different things. But if you don't have a dictionary or a repertoire of who those people are, so we can actually work with students in Boyer or other universities and sponsor someone to actually get us all the specialists and who does what in Cameroon so that other doctors can refer to. Yeah. So please, we have 5 more minutes. Any last, before I'm going to give maybe a last word to Professor Hale. I don't know if Prof wants to say something or not, but so if not, I think we have come to the end of the session, and I want to thank you all. We will do this again next year during Breast Cancer Week. To me, it's a breast cancer thing I do every time. We'll do it again next year during Breast Cancer Week. And we're planning to do other sessions, including prostate cancer lectures. We did a prostate cancer town hall, but we're doing prostate cancer lectures, which is one cancer I realized that is also having a problem in Cameroon in management. We would do cervical cancer, the most common cancers. We would provide CME lectures for those cancers. And please, if you have last words, you can always unmute yourself, and then we get to know you, just introduce yourself, and then we go from there. If not, goodbye, everyone. Have a wonderful Sunday. And it's always a pleasure. Let's end the session.